Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the Meded 101 Nursing Pharmacology Review course. I'm going to cover the basics with atrial fibrillation and obviously focus on the most commonly used medications here. So some generalized symptoms of atrial fibrillation. Can be generalized fatigue, but most patients are going to report a feeling of fluttering, a thumping in their chest. Some dizziness can happen with that fatigue as well, and just a sensation of their heart racing. Okay, other things that can be associated with it, shortness of breath, feeling faint, confusion, and exercise can exacerbate that fatigue as well. All right, so medication-wise, we typically try to control the heart rate with medications. And I went over beta blockers. I touched on calcium channel blockers a little bit as well within the hypertension section. But really, beta blockers are going to be the first-line agent with calcium channel blockers. Important distinction here, it's going to be non-dihydropyridine calcium channel blockers. So that would be like diltiazem or verapamil. And then digoxin, which is a new medication to us in this webinar. Okay, so clinical medication pearls, beta blockers I alluded to, usually first line, with metoprolol being the most commonly used agent that I've seen in practice. We generally avoid the non-selective beta blockers like propranolol, because we don't want to impact, there's no reason to block beta-2 receptors. Remember, beta-1, those are the receptors on the heart, and by blocking that, we can help reduce the heart rate. Calcium channel blockers, non-dihydropyridines, diltiazem, verapamil, recall that they work on the heart, not just the vessels, comparing to the dihydropyridines like amlodipine. So by working on the heart, having that action, slowing the heart's action, we can bring down the heart rate and obviously help manage atrial fibrillation by controlling the rate, often referred to as rate control. Generally, that target heart rate is less than 80 beats per minute. May vary a little bit based upon if the patient's reporting symptoms and other things going on, but generally less than 80 is a good target. Obviously, these medications can drop it further and sometimes too far, so we may have to adjust those. So, as a nurse monitoring pulse, that's going to be super important here, obviously. You start dropping a patient, into the 50s, low 50s, 40s, we're starting to get really, really concerned that's maybe a little bit too far. So 60 is kind of a good cutoff to start thinking like, hey, maybe I should, notify my provider of this. Less than 55, less than 50 for sure. Making sure that provider is aware ASAP is really, really important. With these medications, so the beta blockers and the calcium channel blockers, they were antihypertensives. So we got to be careful with blood pressure, and that's going to be a really, really important monitoring parameter to make sure that doesn't get too low. Calcium channel blockers, a little bit more on them specifically. Verapamil, brand name Verilan, diltiazem, brand name Cardizem. Those are the most common that I see utilized. Again, these can act on the heart and the vessels. I will say there is a bunch of different dosage forms with some of these agents. There's extended release, immediate release, so on and so forth. So pay attention to that. Make sure that we're getting the correct medication there. Utilizing it for rate control, we're going to be monitoring that pulse. There are interactions through CYP3A4, so that is a potential downside to these medications and something that you may want to look out for. With calcium channel blockers, you always got to think about edema, swelling around the ankles. I've seen numerous cases where a medication like verapamil has been started, and within 2 weeks, 4 weeks, or so on, we end up with a a prescription for a loop diuretic like furosemide to help run off fluid, okay? When in actuality, it was simply an adverse effect from the calcium channel blockers. So paying attention to that, watch out for that edema, super, super important with calcium channel blockers. Not to mention, there's a high probability that adverse effect could show up on a pharmacology exam or board exam. Constipation can happen, definitely associated with these agents as well. Again, dihydropyridines are not used for atrial fibrillation. They are more so used for hypertension. All right, next agent I wanted to discuss is digoxin. This can also help control the rate. Mechanistically, it inhibits the sodium-potassium ATPase, which can ultimately increase contractility of the heart and affect cardiac pacemaker cells and help get that heart rate under control. Again, used for rate control, and the situation you're probably going to see this medication used the most in is if you've got a patient that can't handle the blood pressure drop of a beta blocker or a calcium channel blocker. So digoxin does not affect those vessels near as much as those other agents do, so it doesn't drop that blood pressure as low. Now, digoxin is more of a narrow therapeutic index medication. So if you remember that from earlier on, narrow therapeutic index medication, there's always a fine line between under-treatment and over-treatment or toxicity. So in this case, we actually are going to typically monitor digoxin levels with this medication. And for atrial fibrillation, we generally target a little bit higher levels, 0.8 to 1.2. And in heart failure, which I won't talk about that too much more here, but heart failure, we can generally get by with a little bit lower dose. All right, so monitoring parameters, important for you to definitely know. Poor appetite, weight loss, we can drop that pulse too far. Under significantly high toxicity, we also can have visual changes and have yellow vision, or vision can be blurry as well. So remember, GI, weight loss, poor appetite, those all kind of go together. If I have a patient with significant weight loss over, 2 weeks, a month, 2 months, I'm definitely looking at digoxin and potentially checking a digoxin level to see if anything's changed there. Okay, so definitely an important one to remember there. This medication can accumulate as kidney function declines, so we may have to dose adjust there. Always good to have that kidney function monitoring there as well. Another potential risk is potassium levels. So low potassium or magnesium can potentially increase the risk for arrhythmias as adverse effects. So we're probably going to get these labs before we start this medication. So potassium, magnesium, as well as I typically would recommend creatinine, which is a measure of kidney function. Those are going to be important to make sure that this medication is safe. And then one drug interaction, amiodarone, can potentially increase digoxin levels. Now, if rate control fails or stops working, you may see providers try to control the rhythm with a different antiarrhythmic. And one of the more commonly used ones here is amiodarone. Mechanistically, this is a class 3 antiarrhythmic that prolongs phase 3 of the heart's action potential by inhibiting potassium and sodium channels. Now, this is an antiarrhythmic. It's not on the heart rate control side of things. It actually, tries to change and alter that rhythm, like on an EKG, for example. Amiodarone has a ton of drug interactions through CYP3A4, so that's why it's important to monitor any new medications or changes there. And you may see this QTC prolongation risk increase as well. Some antibiotics can increase this risk, antipsychotics, citalopram. This can lead to profound cardiac complications if that QT interval is too long. So you'll definitely see EKG monitoring periodically with this medication. Other monitoring you'll see, LFTs. There's a boxed warning for liver toxicity. Remember, LFTs are liver function test. Thyroid function, so you'll see a TSH, thyroid stimulating hormone, checked periodically. And lung function is also important. Amiodarone can contribute to pulmonary fibrosis. Now, I will mention this briefly. In atrial fibrillation, that heart essentially fluttering, we can increase the risk of blood pooling within the heart. And when blood pools or it stops moving, what's going to happen is it's going to clot, right? If you have a scratch and you get blood on the outside and that blood stops moving, it starts to coagulate, to come together and harden up. And when we get atrial fibrillation, there is that risk of blood not adequately being pumped, and there's the small potential for some pooling. And so when that happens, the heart can sometimes pump out a little blood clot or potentially a bigger blood clot, depending upon the situation. And that blood clot can go straight into the lungs, and that would be in the form of a PE or a pulmonary embolism, and it can go straight up into the brain. And obviously that would be a stroke. So that can be really problematic. Anticoagulation for patients with atrial fibrillation is typically very important. And we have this kind of risk calculation. It's called the CHADS-2 VASC scoring. And I really want you, to pay attention. If you've got a patient with atrial fibrillation, they definitely need to be assessed for anticoagulation and see if they need a blood thinner. And coming up in a future lecture here, I will go through some of those blood thinners that are commonly used in atrial fibrillation. Hey, nurses and nursing students, want to reinforce pharmacology without boring old flashcards? Check out the Nursing Pharmacology crossword puzzle book from MedEd 101. It's an Amazon bestseller. It turns drug classes, mechanisms, side effects, and high-yield facts into fun, brain-boosting puzzles that help you remember what matters most. With over 2,000 questions and clues, it's perfect for study breaks, group review, or solo practice. This book makes learning pharmacology engaging. Grab your copy and start mastering meds in a way that's actually fun. Find it now at meded101.com/nurse. That's meded101.com/nurse.